Okay, just a quick demonstration about incoherent medical patient, how we want you to approach and assess this patient. So you walk into an environment, you've been dispatched for a patient that has an altered level of consciousness or what have you. Walk in, family members here. We approach our patient. We're gathering from the scene that we have one patient. Do we need additional resources, which we may when we find out a patient, and if this is a medical or trauma patient, and from the history it sounds like a medical call. We'll approach our patient observing their skin color, and if they have any level of distress. Body position can also indicate that. We'll assess their level of consciousness. They are not interacting with us, so we'll try verbal. Sir, can you hear me? If they have no response to verbal stimuli, then we'll try some painful stimuli. If that is unsuccessful, then we will say the patient is unresponsive. Given that they're unresponsive, we'll come up to the head and check their airway. And if you had any suspicions that they may not have a pulse, then we'll check a pulse for CAB instead. So let's say that we feel a pulse. I'll come up to the airway and look in the airway. Is the airway patent? Is there anything in it? And is the tube open? And it will say nothing's in the airway. We could delegate our partner to get some adjuncts in the airway. We'll assess breathing as far as rate and depth. Do we have adequate minute volume to sustain life? If we don't, we'll delegate positive pressure ventilation. We'll say that we have adequate tidal volume at the moment. I'll go back to pulse, feel what is rate, rhythm characteristic of the pulse. We'll say that we have a bounding pulse that's readily palpable. So then we'll do our rapid physical assessment. We'll look at the patient's pupils, see if they're pearl, if there's any conjunctival pallor. Look in their mouth, see if their mucosa is dry or not. Any scars, rashes, and lesions throughout the entire body. Is the trachea midline? Do I have any elevated jugular vein pressure? I come to the chest. I'll push on the chest to see that everything's intact, no scars, rashes, or lesions. Take out my stethoscope and I'll auscultate at least 4 points at this point to hear that I have good air entry and no adventitious breath sounds anywheres. And I'll take a moment and just listen over my mitral valve and see what heart sounds sound like. Then I'll come down to the abdomen, look, is there any scars, rashes, or lesions? I'll push on the abdomen, see if it seems distended or soft. I'll come to his pelvis, see that I don't see any evidence of any trauma, no scars, rashes, or lesions. Note whether the patient's incontinent of urine. Then I'll come down to his feet, see what color is like as far as circulation and temperature. Won't be able to assess motor and sensory because he has an altered level of consciousness. Come up, look down his arms, see if there's anything on his arms, and assess cap refill and feel for bilateral pulses. At this point, I can delegate my partner, if they haven't already, to get a full set of vitals for us. If SATs are below, we'll find out history, but below 90%, we'll definitely get some oxygen on, and we'll find out if they have any chronic lung disease. For other oxygen. So we'll get a vital sign starting with SAT to begin. Ask the family, what happened? When did this start? How long has your loved one been like this? Did it start suddenly or gradually? Did they have any other complaints before this happened? Once I have a clear understanding about onset, provokes isn't applicable. As far as quality, you can ask, have they ever had anything like this before? Obviously, if they have, we'd be interested, what did they do last time? And what was the diagnosis last time? Severity is not appropriate, given it just seems severe. We don't need to rate it. And try to firm up a clear understanding. So when were they last well? How did they start to get sick, and how did that storyline progress? Then we'll get an allergies, any past medical history, or any medications, any new medications, any recently discontinued medications, and then past medical history, to any diagnosed medical conditions, any problems with their brain, no history of strokes, seizures, anything like that. Any problems with cardiovascular system, heart attacks, arrhythmias, problems with valves, peripheral vascular disease, anything that might be a previous history of heart attacks. to any problems with their lungs, histories of pneumonia, chronic lung disease, anything of that nature. Any problems with their bowels or a urinary system, how has their eating and drinking been lately, any diagnosed diseases there, and any history of endocrine problems. So just a quick survey through medical history, and then we can progress through to our differential diagnosis based on everything that we found. So important in your incoherent medical patient that really we're supposed to be addressing any problems with A, B, or C. And if it doesn't relate to A, B, or C, delegate your partner to get vital signs, to get an IV for you. But we just want to do the whatever minimum treatment to get airway adequate, breathing adequate, and obviously pulse needs to be present, or we'd have to start CPR, and defibrillation would be appropriate. But try to limit treatment until you get a full physical assessment, get an understanding of what happened today through OPQRST, get an understanding of their past medical history from ample, and then think through a differential diagnosis and what you think this is likely to be, and what else it could be presenting as. And that's a much a safer way of practicing as you're managing these patients. Just try to stay to the minimum treatment till we have a full understanding of what is going on today.